In this section, we'll talk about the middle cerebral artery, as well as what happens when there's a disruption in this artery. So the middle cerebral artery, or the MCA, in the image on your right, is the beige or tan area on the brain. You can see that the MCA really provides blood supply to the majority of the dorsolateral convexity of the brain. Like the ACA, the MCA has several branches and segments, which we won't talk about each one in depth. However, we will talk about the overall effects of stroke within the major areas of the MCA. So the MCA runs along the base of the brain and then enters the sylvan or lateral fissure, where it splits into inferior and superior segments. The superior segment provides blood supply to the latero-inferior frontal lobes, and the inferior segment provides blood supply to the lateral temporal lobe and the anterior and posterior parietal lobes. There are also smaller perforating arteries, the lenticulostriate arteries of the MCA, that provide blood supply to the subcortical structures, and we'll see this in the next few images. So again, in this image, you see a coronal view of the brain, and we can see here again the MCA coming up and through the sylvan fissure and then splitting on both the left and the right side into superior and inferior segments. And then we see these smaller perforating arteries that are feeding the more subcortical structures of the brain. And finally, in this image, we see the dorsolateral convexity of the brain, and it's just another depiction of the MCA, where you can see the superior segment towards the front left and the inferior segment towards the lower right. We can see that the MCA really does provide blood supply to a large area of the brain, and most of the strokes we see, about 2/3, do occur in the MCA vasculature. And so it's really helpful to be aware of the physical, cognitive, and emotional consequences of a stroke to the MCA. So let's talk about that. I've broken it up into the superior and inferior divisions, left and right. So let's start with the superior division, which we saw earlier on the images. A stroke in the left superior division of the MCA might result in right face and arm weakness and sensory loss. Again, this is due to the location of the face and arm on the motor strip. We also oftentimes will see what's known as a Broca's aphasia. It's underlined because I plan to come back and talk about this in more detail. We also tend to see an ipsilateral gaze preference in some cases if the frontal eye field is involved. And so on a left-sided stroke, you might see a left gaze preference. On a right-sided stroke, the MCA, you might see a right gaze preference. So the gaze preference tends to be ipsilateral to the stroke. In a right superior division MCA stroke, we'd see the contralateral face and arm weakness and sensory loss, so left-sided. And again, we tend to see more neglect when we have a right-sided stroke, and that's because of the role of the right hemisphere in self-awareness and sustained attention. And so with a right MCA superior division stroke, we might see that hemi-neglect. Let's go to the inferior division. When we have a left-sided or language-dominant side, also could be referred to, stroke in the MCA inferior division, we tend to more frequently see Wernicke's type aphasia, which again I'll discuss in more detail shortly. We also will tend to see right visual field deficits, like a visual field cut, as well as sensory loss and motor weakness on the right side. If we have a right inferior division MCA stroke, again comes in that hemi-neglect because it's more common in a right-sided stroke and can be very significant with an inferior division right MCA stroke. We also see left visual field deficits like a field cut, And at times it can be difficult to assess the extent of sensory and motor loss with this type of a stroke due to the severity or the profoundness of the neglect we sometimes see with this kind of a stroke. And so it's important to keep in mind that we want to make sure that we are assessing appropriately for neglect as well as sensory and motor loss. Now let's kind of zoom out a little bit and talk about the left MCA in general and then the right MCA in general. And we're taking away now superior and inferior divisions. So again, a very common finding after a left MCA stroke, especially in individuals who the left hemisphere is language dominant, is aphasia, which is a language disorder. We also tend to see various types of apraxia, such as ideomotor apraxia. We tend to see visual constructional deficits or visual spatial deficits, meaning the brain's ability to interpret input from the eyes is lacking. In some cases, with very specific types of stroke to certain parts of the brain, we can see what we call a Gerstmann syndrome. It's a rare syndrome, but it results in some very specific consequences: inability to distinguish the right from the left side, inability to name your fingers, and an inability to do math or acalculia. So Gerstmann syndrome is rare, but it does have a very specific set of symptoms associated with it. We might also see executive dysfunction in the left MCA, things like difficulty with problem solving, planning, organization, sequencing of information, and working memory. And then when we have larger MCA strokes, we may also see memory difficulties. On the left side, verbal memory difficulties tend to be greater than the visual memory difficulties. With a right MCA stroke, you might oftentimes see, again, that apraxia. So individuals might lose object gestalt or the whole. They might not be able to see the whole, but they might be able to see details. It's like the saying, losing the forest for the trees. This might occur in this type of an MCA stroke. Again, we see oftentimes this hemi-neglect or the neglect that's very common with a right-sided stroke. Aprosodia, which is an inability to demonstrate prosody in one's own speech or understand the prosody or emotional tones in other people's speech. And so they might sound very flat. Again, we see similar executive dysfunction as well as memory deficits, with visual memory deficits being greater on the right side than verbal. Let's speak briefly about aphasia. Aphasia is a language disorder, and there are several types of aphasia. We'll focus on the most common types: Broca's aphasia and Wernicke's. You can see there's a link here to a YouTube video of an individual who has a Broca's aphasia secondary to a stroke. If you're able to access that video, I recommend you watch it because it can be helpful to see. Broca's aphasia is also referred to as expressive aphasia or motor aphasia or non-fluent aphasia. And that's because with a Broca's aphasia, because of the proximity of Broca's area to the motor strip, individuals will often have effortful, non-fluent, really broken speech. Their speech output will oftentimes be low. A good way to help you remember this is that Broca's is broken. The speech is very broken up. Poor sentence structure is oftentimes seen, so there's no articles or modifiers. People might not use words like the, and, so it's really disjointed speech. Oftentimes, their comprehension or their ability to understand speech is actually intact and functional. Their reading may also be functional, but writing is oftentimes impaired. And repetition is oftentimes poor due to that impaired speech production. Paraphasic errors are also present, especially phonemic errors, and I'll talk a little bit more about what those are in the next couple of slides. Anomia, or difficulty with naming, may also be present. Of note, Automatic speech might be more fluent with Broca's aphasia than effortful speech. So things like cursing or really overlearned daily greetings like, "Hi, how are you? I'm fine, thanks." That type of automatic speech might be preserved in a Broca's aphasia, but more complex speech and sentences are oftentimes impaired. Lesions of Broca's area, which is known as Brodmann's area 44, cause Broca's aphasia. And Broca's area is in the left lower posterior frontal lobe or the inferior frontal lobe. And again, due to the proximity to the motor strip, we see that difficulty with speech production. We oftentimes may also see a contralateral hemiplegia or paralysis on one side of the body, again, because of the proximity to the motor strip. Switching gears to Wernicke's aphasia, again, there's a YouTube video link here. If you're able to watch it, I would recommend it because it helps to see. A Wernicke's aphasia is also called a receptive aphasia or a fluent aphasia or a sensory aphasia. In a Wernicke's aphasia, comprehension is what's impaired. So this is different from a Broca's aphasia. Comprehension is impaired in a Wernicke's aphasia. However, oftentimes speech production may be quite fluent, kind of like my speech is right now. Again, very different from a Broca's aphasia. Speech is fluent, it may be well articulated. However, it oftentimes is nonsensical. The speech may be fluent, but may not have a lot of meaning, and may be filled with paraphasic errors, which we mentioned earlier. Phonemic paraphasias, semantic paraphasias, as well as neologisms. A phonemic paraphasia is saying a word that sounds like the right word, but isn't. So, for example, saying smoon instead of spoon. A semantic paraphasia is an error in which somebody may say a word that's in a similar category, but it's the wrong word. So if somebody is trying to say the word spoon, they may say fork or cup because it's in that semantic category. A neologism is essentially a new or made up word, like snowball instead of spoon. Empty speech is speech that doesn't have a lot of meaningful content and has a lot of filler words like, things, stuff. So again, when you see this kind of fluid but perhaps non-meaningful speech, you might think a Wernicke's aphasia. With a Wernicke's aphasia, repetition is poor because of impaired comprehension when hearing words and because of paraphasic errors when speaking. Reading and writing are usually impaired, and again, we see anomia or naming difficulties. With a Wernicke's aphasia, again, motor function may be intact because this type of an aphasia occurs in the more posterior area of the brain. However, you may see some sensory loss or visual field loss. Lesions of Wernicke's area, which is Brodmann's area 22, are what result in a Wernicke's aphasia. And Wernicke's area is in the left, posterior, superior, temporal gyrus. In addition to Brodmann's area 22, sometimes areas 37, 39, and 40 might be involved, as well as the thalamus. Thank you.